Okay, well, let me know if you can't hear me. I'll try and talk up. I am in a shared office, so apologies if my colleagues do come in. Um, but as Cassie said, I'm a neurologist, but I've been working in the sleep clinic for nearly 20 years now. And whilst I'm wheeled in to try and determine the nature of odd episodes of whether they may be epileptic or non-epileptic sleep events, the process of working and developing within the sleep service naturally enables me as a jobbing neurologist to help the children with epilepsy that I look after, and incredibly valuable. And I hope that some of that experience and can rub off during this presentation. I thought we would just start just having a brief run through of what we mean by seizures, epilepsy, syndromes, and why epilepsy is important. And there have been various new iterations of the classifications over the last few years. But essentially, when we think of an epileptic seizure, we're thinking of a sudden, unprovoked paroxysmal burst of abnormal electrical activity within a region of the brain in a focal seizure, or throughout the whole brain with all of the neurons involved in those networks as generalized seizures. And obviously, dependent on what those electrical patterns and where those patterns are, determines what it clinically looks like as a focal seizure or generalized seizure. And for an individual child, they may have just focal seizures arising in a distinct region of the brain, or they may have generalized seizures of different types, such as absences, atonic, tonic seizures. There may be a mixture of the two in some epilepsies. And of course, there's always going to be a cohort of children and young people where we just don't know. And it's better to say you just don't know rather than force descriptions, and allow time to declare what is going on. And where we can, but we can't always, we try and decide what an epilepsy syndrome is. And by that, I mean sort of age of onset of the seizures, what particular seizure types, what do the EEG patterns look like. So for certain epilepsy syndromes, there's very clear patterns such as childhood absence epilepsy presenting from around the age of 5 with a typical seizure type of behavioral arrest, staring, unresponsiveness, maybe some mild automatisms, a quick offset, and an EEG that shows you 3 Hertz generalized spike wave, boom. We know that with that, usually the seizures subside by 2 years' time, and very rarely do they have adult seizures. If they do, they may have intermittent generalized tonic-clonic seizures, usually when they're sleep deprived. So it gives us an idea of what is going on. But importantly, we also need to think about the comorbidities. And this is really important when we think of children with epilepsies, because it's not just the seizures, it's not just the drugs. It's the nature of what it's doing and what the brain disorder is that's causing the seizures. And we know there's a much higher incidence of behavioral difficulties, learning difficulties, mood difficulties. We know at least a third of children with an epilepsy have a diagnosable mental health disorder, be it ASD, ADHD, anxiety or depressive disorders, conduct disorders. So we always need to be thinking about the child as a whole rather than just the seizures. And as I've alluded to, we've got, when we're thinking of focal seizures, where the electrical activity is arising from in different lobes of the brain. And today we're going to mainly concentrate on the frontal lobe, and we'll get towards the end of the talk go into a bit more detail there. But that's our executive part of the brain, where we are thinking, concentrating, working, memory, our impulse control. But it also contains our motor strip coordinating our movements, and it's the largest lobe in the brain. We've got our temporal lobes on the side of our brains, which are really important, particularly our dominant temporal lobe for understanding language, the receptive language area. Our innermost temporal lobe is linked into our emotional cortex, the limbic system, involved in our fight and flight reactions. And so seizures arising from those inner temporal lobes give an impending sense of fear and distress that you see on the facial expression of the child as the seizure starts. We've got the parietal lobe, which is a massive lobe for mostly sensory motor, spatial organization, and often seizures that arise in this lobe. The electrical activity spreads very quickly out of it, but sometimes there may be a sense of sensation in a part of the body before there's a more obvious motor seizure. And then occipital lobe seizures. Your occipital lobe is your visual cortex primarily, and seizures that arise in the occipital lobe, you often get visual hallucinations, which typically are multicolored, often circular, concentric shapes, starting in those outer lateral visual fields, getting bigger, moving across the visual field, but multicolored compared to the migrainous hallucinations that you get that are typically linear, black and white, with that central scotoma where you lose your vision. So occipital lobe hallucinations are far more exciting and psychedelic and rainbow-like. So that can help you in your questioning between migraine and occipital lobe seizures. So a myriad of different symptomatology that you can have with focal epilepsies. And then we always try and work out what is going on, why is this happening? And we've had an absolute explosion in our genetic understanding of the epilepsies, which is really exciting, mostly for the more severe epilepsies, that epileptic encephalopathy group of children with profound drug-resistant epilepsies, with learning disability, often physical disabilities. And we have got a pretty good strike rate for the genetic understanding of those epilepsies now in our testing. But of course, it's the structural epilepsies, be it a hypoxic injury, a traumatic injury, or injury following infection. You know, these are not necessarily discrete etiologies. It can be crossover here, that you can have genetic and structural. You know, some genetic conditions give you structural abnormalities in how the brain is formed. You know, disorders of neuronal migration and development and cortical dysplasias. So we try to systematically work our way through the understanding of what's caused it, because that can help us in our understanding of prognosis, treatment options. Is surgery a goer for a child with a drug-resistant epilepsy? So we try to get the very best overall understanding of what the epilepsy is for that child, how it's affecting them with the comorbidities, and what's causing it. But getting back to the brief of sleep and epilepsy, it's a complex and it's a reciprocal relationship really between sleep and epilepsy. And the more you think about it, the more you see how intertwined these two things can be. We know that there are certain epilepsies that manifest mainly, predominantly, sometimes solely in sleep. Bit of a historic slide here calling it Rolandic seizures. It's now a self-limiting epilepsy with temporal spikes. It's not benign because we know that in some children it can have significant cognitive sequelae. But you know, these are seizures that we'll discuss briefly later on, that occur predominantly in sleep. We know frontal lobe epilepsy can occur, you know, solely in sleep. It's very helpful when those seizures occur during wakefulness, but sometimes they don't, and make that diagnosis a bit more tricky of whether it's a parasomnia or a frontal lobe epilepsy, and we'll explore that later. We certainly know that sleep deprivation, particularly with the generalized epilepsies, can be a strong provocation for seizures, particularly those early morning bilateral tonic-clonic seizures. And that can be the first time that a generalized epilepsy, such as juvenile myoclonic epilepsy, can present following a sleepover, following, you know, reduced sleep from illness or whatever reason, less sleep, and then the following morning having their first tonic-clonic seizure. And thereafter, with these generalized epilepsies, managing sleep, getting enough sleep, sleep at the right time, is really important for this group of adolescents with these JME, JAE epilepsy syndromes. That's a strong factor in the overall management of their epilepsies. We utilise sleep deprivation and sleep in the diagnosis of the epilepsies. You know, once we've got our clinical strong hypothesis that this is likely to be a seizure disorder, we then order our EEG, and sometimes the wake EEG doesn't show us any abnormalities. Now, that doesn't tell us it isn't an epilepsy. And so if our hypothesis is strong, we go on to do a sleep EEG. And that can be natural sleep if we're doing a prolonged EEG, or sometimes an ambulatory EEG to definitely capture sleep, or a melatonin sleep induced EEG. And that helps bring out the epileptiform discharges and help with our overall diagnosis and where these seizures are arising from. Again, we'll come to it later on, but we know, and there is evidence to show, that children who have epilepsy have poor quality sleep. They have poor sleep patterns, less sleep, that can result in excessive daytime sleepiness. And of course, you know, epilepsies that have nocturnal seizures and disrupt sleep can also reduce total sleep time, particularly those seizure types such as tonics that can occur numerous times during the night in children with Lennox-Gastaut syndrome. And so, you know, this is where we see the overlap, and there's overlap between the, you know, these individual boxes. It's all one big overlap. But, you know, thinking about sleep disorder and epilepsy, you know, we've had numerous periods of time in the UK where it's been highlighted that there's been a high misdiagnosis rate of epilepsy in children. And that's really what initiated the drive for Epilepsy 12 in improving our understanding and diagnosis of the epilepsies, because sleep disorder can be mistaken for epilepsy and epilepsy mistaken for sleep disorder and vice versa. And it can be challenging to get that diagnosis. And, you know, in studies looking at misdiagnosis of the epilepsies, as high as 50% of primary care referrals can be wrong. And even within secondary care, the study showing still up to 30% there can be misdiagnosis. And I dare say within my tertiary epilepsy clinics, I've sometimes got it wrong, and I have diagnosed epilepsy when it's not, and vice versa. And that's why one needs that high index of scrutiny when we're seeing our young people in clinic, and follow-ups of what's going on, not controlled, why is it not controlled, have I got the diagnosis right, go over the story again, try and get video footage, because misdiagnosis is alive and well in all of our clinics. We know that sleep disorder can make epilepsy worse, and you know that can come about in numerous situations. That can be, you know, predominantly sleep disordered breathing, for example. Pardon me, you know, we've got, you know, plentiful evidence that, you know, in children with a, you know, drug resistant epilepsy, if they've got sleep disordered breathing, that can make it worse, and treating the sleep disordered breathing can improve seizure control. We think about children who've got an epilepsy, particularly seizures occurring at night, high degree of parental anxiety, vigilance, presence, that child associates parental presence with sleep onset, sleep waking, and you know, you have a sleep onset association disorder with numerous night wakings. So there's various, you know, sleep disorders that we can see in children with epilepsies. And of course, both can coexist. You know, a child can have numerous different types of episode, and they all need to be considered on their own merit, rather than assuming that they're all seizures or all non-epileptic events. And when we're thinking about treatment, you know, certain epilepsy drugs such as the benzodiazepines, the barbiturates, affect sleep architecture and reduced REM. So that can affect your sleep patterns. And I've already alluded to, you know, such as sleep disordered breathing, the treatment can improve epilepsy, such as managing obstructive sleep apnea with CPAP or tonsillectomy. Now, this is a really old slide, but this paper came about when I was just starting my sleep odyssey with Kathy and her team. And I think it, you know, is still relevant. And Greg Stalls looked at 79 children with epilepsy, matched to 73 healthy age-matched controls. And there was a myriad of different experiences in the children with epilepsy having higher rates of poor quality sleep. They had anxieties regarding sleep. Were they going to have seizures in sleep that night? There's a higher incidence of sleep disordered breathing, and they had shorter duration sleeps. And one's got to hypothesize that is this a further contributor to the learning and behavioural difficulties that we see in this group of children when we're thinking about comorbidities in children with epilepsy. And there have been more recent studies, and these are three that I've picked out. The first one looking at the value of combined EEG and PSG when you're trying to differentiate what these paroxysmal events in sleep may be. Are they epileptic? Are they parasomnias? And this is clearly quite a hefty resource that cannot be wheeled out readily in all environments, but occasionally it can be very useful when you're really not sure what the nature of events are with a high index that they may be epileptic. But in this study, whilst, you know, 40%, you know, did have an epileptic seizure captured on the EEG, and that was helpful in determining what these events were, they also, you know, captured parasomnias. And, you know, in the group who were having seizures, they also noticed that their PSG was abnormal, and they were noticing that sleep disorders, reduced sleep time, maybe lower oxygen saturations were more prevalent in the epilepsy group. And then in the second paper, they were looking at that group of children with the really difficult to control epilepsies, the epileptic encephalopathies, where we know it's the epilepsy, we hypothesize it's the epilepsy itself with the severely abnormal EEG that is part of that cognitive deterioration and learning disability that is often drug resistant. And within, you know, this study, they looked between 2015 and 2017 and had 31 children, equal mix, well, slightly more boys actually than girls. And they found that children with the epileptic encephalopathies who were on their epilepsy meds had significantly decreased total sleep time, significantly increased percentage of non-REM, less REM, and they also had markedly reduced oxygen, mean oxygen levels, and greater dips in their oxygen saturations. And so really highlighting that children with epileptic encephalopathies, we should be thinking about their sleep studies, their oxygen levels. Is this a further aspect that's part of their epilepsy control? And then the last study really looked at three groups in healthy controls. They looked at new onset children with focal epilepsies who'd not yet started medications. And then they looked at those children with focal epilepsies in whom they were still having seizures. And they found that you'd almost think intuitively the group with the drug resistant focal epilepsies had what they showed to be disturbed sleep architecture, significant reduction of time in bed, reduction in total sleep time, reduced sleep efficiency, and significant increase in awakenings after sleep onset. Also an increase in periodic limb movements. So quite a wide spectrum of sleep difficulties in that group. But even in the drug-naive, newly diagnosed focal epilepsies, compared to the healthy controls, they noticed increase in sleep onset latency, so time taken to fall asleep, an increase in sleep awakenings, and again, a significant decrease in time in bed compared with controls. So yeah, it's even taking medications, which some people think are the cause, which very rarely they are. It's the brain disorder that's often driving this, which, you know, this paper points towards. And there was one further study that looked, these are not big studies with massive numbers, but they give us an idea of what's going on, and they're all pointing in the same direction. But this was 40 children who all had epilepsy. And I think they all had, you know, difficult to control epilepsies of various types on this occasion. And they had PSG primarily for sleep complaints rather than diagnostic reasons. So you see the majority were snorers. And of those 40 children, 42% had on PSG sleep disordered breathing. As you can see there, various forms of, including obstructive hypoventilation, obstructive sleep apnea. 10% had periodic limb movements, which will disturb sleep architecture, less refreshing sleep, less sleep. And then children with poorly controlled epilepsy had lower sleep efficiency. So it's a theme we're seeing coming round, higher arousal index. And this should be lower REM sleep, sorry, mistake there. So, you know, just think about children with epilepsy, and do they need sleep studies if they've got, you know, if particularly if they're snoring and they've got poor seizure control. So, you know, this was a study in moving on from those with obstructive sleep apnea in those children with refractory epilepsy. They looked back at 27 children with epilepsy who'd had surgical treatment of obstructive sleep apnea. And they noted seizure outcome 3 months post-op. I'd say 3 months is a pretty short period of time. You know, some children have relatively infrequent seizures, and usually for a drug, we're looking at 6 minimum, preferably 12 months to get an idea of effectiveness of that intervention. But nevertheless, they found that approximately a third were seizure-free, 11% having a greater than 50% reduction in seizure frequency. And that's what we're looking for usually with a drug. And so, you know, you've got 48% having greater than 50% reduction in seizure frequency, and you'd take that any time of the day if it were a drug. A fifth showing greater than 50% reduction in seizure frequency, and a third unchanged or worse. And those with an increased BMI or younger age had best benefit from that intervention and improvement in seizures. And certainly in my clinical practice, I've certainly got a handful of children, largely with epileptic encephalopathies, who also have non-invasive ventilation because of obstructive sleep apnea. And it's definitely improved their seizure control. They're not seizure free, but it's another piece of the jigsaw in helping improve the seizure frequency and intensity, but also managing that sort of post-seizure phase, that post-ictal phase, often where there's reduced pharyngeal tone, greater risk of obstructive airways. So always think in children with epilepsies that there is a higher incidence of sleep disorders. So, you know, think about asking the questions in your epilepsy clinics. Think about, do they need sleep studies? I particularly think about obstructive sleep apnea. So moving on to the second half of this talk, in thinking more specifically about certain epilepsies and differential diagnosis of paroxysmal events. So when we're thinking about seizures in children with epilepsy, this study looked at 188 individuals who had refractory drug-resistant epilepsy, by which I mean they've tried 2 drugs and still having seizures. So it's about a third of individuals with a diagnosis of epilepsy. They captured 1,000 seizures. A fifth of those occurred during sleep. And this is what gives families a lot of anxiety of those seizures occurring in sleep. Of those seizures that occurred in sleep, the majority of them occur in stage 2 sleep. Very few seizures occur in REM, and we largely see REM as almost protective in sleep. It's a relatively short amount of sleep, though. And when you look at the EEG in REM, it most closely aligns to the EEG that we see in wakefulness. You haven't got those slow undulating waves where there's synchronous brain activity. And we think that when there's synchronous brainwave activity, it's much easier for a seizure to generate and propagate its electrical pathways. It's noted that when focal seizures occur from sleep, they often last longer if they arise from sleep than if they arise from wakefulness. And, you know, in those that have looked at temporal lobe seizures occurring in sleep, they're more likely to generalize into bilateral tonic-clonic seizures if they occur from sleep. And the hypersynchrony is just what I was talking about in that non-REM sleep. So, you know, we think it probably facilitates an easier propagation of electrical pathways in sleep compared to wakefulness. And this is just another sort of graphical way of showing, you know, the red bars are just showing what the natural expected percentage sleep is. And we know that the predominant sleep stage is stage 2 sleep, but there's a disproportionate predominance of seizures arising from this stage and stage 1. And this aligns with what parents often say, isn't it? That, you know, they often observe that if seizures are going to occur, they typically occur in that first hour or two. And generally, if they haven't occurred by then, they're a little more relaxed, that they're not going to have a nighttime seizure. And that fits with where we see those stages. Of course, we see stage 2 in sleep cycles, you know, throughout sleep, but we see a big chunk of it as in sleep onset. And when we're thinking of, you know, value of sleep EEG, Beth Mallow has done a lot of work in adults and in paediatric practice. And most of the work I've read that she's done has been regarding obstructive sleep apnea, actually. But she looked at individuals with temporal lobe epilepsy, showing that of her cohort of 24, 11 didn't have any discharge, did have discharges, sorry, on routine EEG, but on sleep EEG, which I suspect was a very long one, she managed to get discharges in all of them. My practice is not quite so successful, but it definitely significantly increases the yield in doing a sleep EEG. So when we're thinking of sleep-related epilepsies, you know, these do not occur solely in sleep, but may occur predominantly in sleep and may be misdiagnosed as parasomnias, although I suspect that the predominant one that's causing mischief is that of the nocturnal frontal lobe epilepsy, which we'll go into in a little more detail. The next slide, I'll also go into a little more detail of the childhood epilepsy, self-limiting epilepsy with centrotemporal spikes, moving on to Landau-Kleffner and electrical status in slow wave sleep. But the self-limiting childhood epilepsy, the occipital epilepsy of Paniatopoulos, is an interesting one. I don't know if any of you have seen it. It's a really interesting seizure disorder in younger children. So may occur from 3 years onwards, where it's seen as a sort of autonomic focal epilepsy. So occipital epilepsy is a bit of a misnomer, other than you often see a predominance of discharges on the EEG in the occipital region. But these children present confused, appearing encephalopathic, and vomit a lot. They look pale. And so their original presentation is often of a questionable encephalopathy, encephalitis, and some may end up on intensive care and then wake up right as rain as if nothing ever happened, which is clearly not the picture you'd expect with an encephalitis. And you do the EEG and they've got predominantly occipital spikes, but they may get spikes in other regions of the brain. And that might be a one-off, or it may occur a couple of times before they grow out of it. The seizure disorder of Lennox-Gastaut syndrome is a really devastating epilepsy syndrome, which is the kind of end result of any number of underlying etiologies. It can be genetic, it can be the result of meningitis, brain injury, hypoxic ischemic injury, it can follow West syndrome in infancy. So it's not a diagnosis of cause, it's an epilepsy syndrome where you get a seizure onset in early childhood of tonic seizures, atonic seizures, and atypical absent seizures with a typical EEG of slow 2 hertz spike wave. But, why are we talking about this in the sleep talk? Well, they get tonic seizures predominantly occurring in sleep, and they can occur 10, 20, up to 50 times a night. And you can imagine that absolutely wrecks the quality of sleep, because often they wake from these brief tonic seizures and often want parental reassurance. So you can well imagine this is a really tricky epilepsy to manage, not least it's drug resistant, but also the knock-on effects with sleep deprivation, and that acting as a further trigger for ongoing poor seizure control. And you don't want to over-sedate these children either with medications, because if they're in a sedated fugue-like state during the day, and we know they predominantly have seizures in sleep, then you're almost increasing the risk of them having seizures in daytime because they are sleepy and sedated. So they really need a delicate hand in thinking about what are you trying to achieve in the management of their epilepsies. You're trying to keep them unsedated, trying to find the best combination of medications, and that's not always easy. And then we've already discussed, those epilepsies that may manifest soon after waking or with drowsiness, particularly juvenile myoclonic epilepsy, a young person's epilepsy, often presenting with early morning myoclonus that interrupts their fine motor dexterity. They're jerking, they're dropping things, eating their cereal, the spoons flying milk around. It's frustrating, but they may not disclose that. You have to ask, are you a bit jerky in the morning? But they may present with an early morning tonic-clonic seizure as their first presentation of epilepsy. And as I said before, that may follow an episode of sleep deprivation. So always ask what happened the night before. And so often in JME, there's been something leading up to it that's reduced their usual sleep volume. So self-limiting childhood epilepsy with centrotemporal spikes, again, as the name says, self-limiting. But, it's got a sort of spectrum of how much it impacts on the child. Some can only have a few of these seizures and never need medical treatment. In others, they have more frequent seizures, and it does affect cognition or language to a degree, and they may warrant a period of time where they have drug treatment. But these are focal seizures arising, and this is the homunculus distributing where various body parts are mapped out on the motor cortex here, which is along the side bit of the brain, and the sensory strip, which is next to the motor strip in the parietal lobe. And where you get these seizures arising from is in the kind of face pharynx area, in the sensory motor strip. So the seizure presents, as you would expect, with electrical discharges in that region of the brain, with one side of the face, a sensory motor, throat noises. They can't swallow, so they're hypersalivating. They might make a sort of guttural noise. There might be some jerking or contortion of the side of the face. They're usually conscious at this stage. If it's their dominant hemisphere, they may not be able to speak. So they often go and find a parent, or if it's occurring in the night, it may then generalize into a bilateral tonic-clonic seizure, and that's how the parent is alerted to them. but they have a typical EEG pattern with these centrotemporal spikes that may only be observed in sleep. And here you're getting these left, so the odd numbers are left-sided, C for central, T for temporal. You're getting these centrotemporal spikes with a slow wave here. And then they're sort of building up in frequency that you're seeing them more obviously, sometimes then being seen bilaterally, but here they're predominantly seen on the left side of the brain. And that's might be all that you see. But for some children, and for reasons we don't understand, sometimes when they're treated with carbamazepine, or a natural history of this condition, is that these spikes really take off and occur more frequently and more extensively in slow wave sleep. And as I said, sometimes that can be precipitated when we start carbamazepine. And then there's this evolution into this condition called electrical status epilepticus in sleep. Bit of a mouthful. And it can evolve in a child with a focal seizure disorder that in of itself may be a really infrequent focal seizure disorder that might have been reasonably well controlled on medications. But then there is a sudden change in the child, be it cognitively. Their language may change. They may be drooling more. They may be more unsteady. And if you've got a child with previously reasonably well controlled focal seizures who's presenting in this way, always try and get a sleep EEG to see if it's evolved into this. Because not unsurprisingly, this has a sort of huge cognitive burden on the child, because this activity is going on for at least 80% of the slow wave sleep. And as you are hearing in these courses, slow wave sleep is a really important time for memory consolidation and learning and cognitive processes going on that are going to be interfered with if you've got this electrical storm going on during sleep. And when we're thinking about ESES, we call it an encephalopathy, where it is the time where you treat the EEG, not the seizures. And it is very much an age-related phenomena. Adult neurologists don't see this. And no matter how bad ESES is, it burns itself out by adulthood. But obviously, if it starts in a young child and continues until their teenage years, time spent in ESES will have a huge negative burden on their learning. And some individuals go into ESES and they come out of it within weeks and months with treatment. A huge spectrum of how drug resistant this is, how it affects the child, and how long it lasts for. And very much where the kind of focus is, be it frontal lobe or temporal lobe, or over the speech and throat areas, the opercular areas where your Rutlandic, your centrotemporal spikes come from, determine what that physical phenotype is like. And so, as I've said, you've got a dramatic decline in cognitive abilities. And so if this is being driven from the frontal lobes, really this is where the cognitive decline is really stark. They can't think, their executive functions affected, impulsivity, their language deteriorates, behavior, attention, concentration, all these things deteriorate. If they're occurring over that region that we see in the self-limiting centrotemporal spike epilepsies, then you can imagine there's speech difficulties, dysarthria, there may be speech arrest, you can't understand, language, and they may be drooling copiously. They've got this bulbar palsy. And if it's occurring over the temporal lobe, particularly the dominant temporal lobe, where you have your areas of speech understanding, you get a receptive aphasia. And if you can't understand what is being said, you can't really speak language. And this is where you get, Landau-Kleffner disorder, where at its most severe, children don't even recognize familiar sounds such as birdsong or a telephone ring. Those sounds mean nothing to them, and they have huge cognitive burden. So as I've said, the duration as well as the location relates to that final neuropsychological functioning and disorder for that child. So towards the end, then, let's think about frontal lobe epilepsy and how we determine it from parasomnias. So your frontal lobe is your biggest lobe in your brain. It's a complex lobe that serves numerous functions. Your motor strip is just along here, and then it's got all those other executive and motor functions within it. You know, I don't expect you to remember this, but this is just, you know, highlighting a sort of simplified version really of different functions. And I've highlighted two regions of the brain, the cingulate and the orbitofrontal regions, where you get really quite bizarre and frenetic and motor seizures. And if you think about where these areas in the brain are, the cingulate is a gyrus that is enveloping your corpus callosum, which is the bridge that holds the two cerebral hemispheres together. And it's deep within the brain. And so if you've got seizures arising in here, you can well imagine when you're doing your surface EEG, you might not see any abnormalities on the surface EEG because all that electrical activity may well be hidden deep within the brain. Similarly, the orbitofrontal, this is, you know, hidden under your forehead. You don't get EEG electrodes here. So again, this can be an electrographically silent region of the brain where it's difficult to get EEG abnormalities. If the seizure remains confined to this area, you may see EEG abnormalities if the electrical pathways are spreading more broadly within the brain. So just remember that EEG can be normal in the frontal lobe epilepsies, and they can present with these very strange hypermotor seizures. You've got your supplementary motor seizures arising from the gyrus just in front of the motor strip that help coordinate movement, that is similar to your baby asymmetric tonic neck reflex, where you turn your head to the side and the arm goes out and the arm goes back, and you get these patterns of this fencing posture that helps us determine where that may be coming from, and we look at the scan to see if there's a lesion in or around that area. You've got your motor cortex, where you get your Jacksonian march, that you may get jerking that starts in your finger. It moves up the motor strip to the hand, the arm, the face, down the leg in that Jacksonian march. You've got your opercular, which is here, where you get that drooling because it's involving your face, your throat, your drooling. So, you know, a whole constellation of different seizure types. But if a child's got a frontal lobe epilepsy, they're going to have a distinct type of epilepsy for that individual. They're not going to have all these different types. You know, when they have their seizure, it's going to be very stereotyped for them. Each and every event's going to look very similar. And that's the key to take home from the frontal lobe epilepsies. Stereotyped events, no matter how weird, bizarre, and wonderful they may appear. And so I keep saying the word bizarre, but, you know, they really can be, and complex behaviours. There can be a sudden arousal that can be indistinguishable from a sleep arousal, which is normal, but then followed by other events that can be these hypermotor, these punching, these cycling, kicking leg movements, thrashing type behaviours. It can then evolve that you see more obvious classical seizure phenomenology, such as the stiffening of the arm that may just be one arm, or you get that asymmetric fencing posture, or the whole body becomes rigid. There may be this real look of fear. Temporal lobe seizures, they experience intense fear. Frontal lobe epilepsies, they really look fearful often. The key with frontal lobe seizures is they're often very quick. They last, you know, 30 seconds, but they can be frequent throughout the night, compared to a parasomnia that's often lasting minutes and occurring in the first few hours of sleep. So that can help you. So if they're multiple times a night throughout the night and highly stereotyped, you have got to have the red flag flying that these may be seizures. So let's see if this works. And I forgot to alter the volume. So just be prepared that the volume may be high in your earphones, and apologies for that. So I'll show you the first one. Who's that? Is that 40 seconds? Oh, I don't appear to be able to. Oh no. Is that playing? Let's see. So look at this one. And this one will go in a second. Look what she's doing. And then watch this one. Yeah, so coming up. Look at that arm. So I hope you saw, from those videos, that these are predominantly, but not solely, because she was awake in this one. She had that sudden onset where she was grabbing, scratching at the blankets, that hyperkinetic movement. And with the slightly longer ones, she had of that left arm, that tonic posturing that only lasted a few seconds. And unless parents are seeing it or videoing it, would easily be missed. And again, the parents are alerted to these events by the sound that she makes. But you would imagine, that if she wasn't making that sound, these could be quite silent in sleep. And sometimes, children can be confused after these events. And we've certainly had a number of children and young people over the years that have presented with nighttime distress and agitation throughout the night that's taken a few minutes to settle. And that's actually the post-ictal agitation, and they've missed the seizure. And now with, motion sensitive CCTV type cameras that can capture seizures, that's been enormously helpful in capturing these events and seeing what happens at the very beginning. This girl had a right frontal lesion which was resected, and while she wasn't completely seizure free, had a markedly reduced seizure burden and much improved seizure control, although unfortunately her ongoing mood and behavioral difficulties after years spent with drug-resistant focal epilepsy were an ongoing problem for her in adolescence, highlighting it's not just the seizures. So, you get extra points for noticing the error on this slide. But, to determine between parasomnia and frontal lobe epilepsies, sometimes it remains difficult, but by and large, parasomnias occur in the first 2 or 3 hours of sleep, where there's been deep, slow wave sleep and the child's starting to exit that deep, slow wave sleep. the duration of them is of minutes rather than less than a minute or seconds, and they can last between 5 and 30 minutes. And you know that from, taking histories of children with, sleep terrors. And we're talking largely sleep terrors and sometimes confusional arousals being the non-REM arousal parasomnias here. And sometimes if, there is a very clear bedtime routine and sleep onset, parents can largely set their clock by when they're expecting these events to occur. During the event, the child's still asleep. They have no response during them. They have no recollection the following morning, and we advise, parents not to talk about it because it will create a fear of sleep. And these largely occur as a single event. They may occur every night. They can be worsened by intercurrent infection. They can be worse in the setting of sleep disruption, sleep reduction for other reasons. And sometimes we see parasomnias alongside children who've got a sleep onset association disorder and multiple nighttime wakings and reduced total sleep time, and the parasomnias improve as that is dealt with. And you'll be learning about the parasomnias and how to manage them in other workshops. But comparing them to frontal lobe epilepsy, as I've mentioned, these occur at any time during the night. So when they're occurring throughout the night, it's very unlikely to be a parasomnia. They're brief compared to minutes of the parasomnia. In frontal lobe epilepsy, there may be partial awareness. The child may be aware that they're having a seizure, and they often wake from the seizure and are aware that something has happened. Whereas the parasomnia, it sort of whittles away and then they go back to sleep again and don't know it's happened. And the frontal lobe epilepsies, they're frequent and they're stereotyped. Can't stress that enough, stereotyped. So, if you're not sure about what's going on, try and get a family to record 3 typical events and look at them. And no matter how bizarre, they will have that same pattern throughout the seizure of what their various bits of their body do at various stages. And it will become clear that they are stereotyped. And this was a nice paper by an adult neurologist, Chris Derry, when he was doing his work in the Melbourne epilepsy surgery unit in Australia. And they looked at a group of individuals with definite frontal lobe epilepsies and looking at those with arousal parasomnias and trying to determine if they can see a difference between, the arousal patterns. Because sometimes that can be quite tricky, with children sort of waking from sleep and having these arousals, and are they seizures? And they could see some subtle differences. In both, as you're aware, there were brief recurrent arousals, and at that stage, at the very beginning, they seemed quite indistinguishable. But as both parasomnia and seizure continued and evolved, the motor patterns seen in the frontal lobe epilepsy, you won't be surprised to hear, were highly stereotyped, a bit odd, may have incorporated some limb posturing. But the parasomnia, the motor movements, were more like those that we do innately, sometimes when we're a bit stressed or confused, or just those movements we do without realizing, such as touching our nose, putting our hand through our hair. I've probably done that a few times during this talk. But those kind of sort of fidgety type movements that we all do were more likely to be seen in the parasomnias, who were also more emotional and appeared more distressed. And then during the parasomnia, which was longer, there was this increasing sense of interaction, not a clear reciprocal conversation, but greater interaction that then, gradually burnt off and they went back to sleep again. Whereas there was a clear offset in the epilepsy group that in the majority then had a period of wakefulness of what happened there. So it's more how that arousal evolves and then how it stops that gave them much more sense of differentiation between parasomnia or seizure. So last slide, and just to finish off then, there's always going to be this crossover between sleep-related epilepsies and parasomnias, where there may be these arousals, there may be bizarre events that we are seeing, there may be autonomic involvement in the two groups, but it's how it evolves, it's how stereotyped it is, it's when it's occurring during the night, that gives you a little bit more kind of understanding of what you think is going on, where you're going to put your money, of how you're going to investigate. But sometimes you need to do overnight video EEG and try and capture these events if you're not sure. And I've certainly had a few young people in my epilepsy clinic over the years where I've been on the fence. I've largely not treated them with medications, but I have investigated them with more prolonged EEG, and I've kept them under close watch to see if things change. But largely those who I was fairly sure were parasomnias, but just not 100% confident, grew out of them, and it clearly got better as they got older. So sometimes we have to deal with uncertainty, and that's the nature of what we do, and particularly neurology. So yeah, hopefully a few minutes for questions. Sorry, I've gone on a little bit longer than I expected to, but there we go. I hope you heard me.
That's fantastic, Andrea, all very loud and clear. I can just see one question already in the chat, actually from Ambika. Would you be undertaking PSG for all children with refractory epilepsy in your practice?
No, I usually do the cardiorespiratory sleep studies, and if that doesn't give me any answers, then I do, as you know, Kathy, a fair bit of actigraphy to get a sense of sleep efficiency, and what's going on with timings. But no, the PSG is a valuable resource, and of course, if it were a more available resource, that would be great. But I think there has to be a sort of triaging, where I predominantly use the cardiorespiratory sleep studies.